Bismillah ar-Rahman ar-Rahim. Welcome to this series, MRCP Made Easy. We are going to start with cardiology section. Pulmonary embolism is a common problem in real life practice and also is a common topic in the exam. Questions in pulmonary embolism scenarios are like other questions. So they usually include the best initial investigations or the definitive diagnostic test or the best treatment or best initial therapy, or may ask about the most likely underlying cause for the condition of the patient. So usually the scenario asks about the patient who is presenting with acute shortness of breath with associated chest pain. There may be also some details about some risk factors of DVT or pulmonary embolism. So common scenarios include long trips. So usually you will find in the scenario that the patient present after a long trip from Australia or from United States, something like that, or from the Far East, or maybe post-operative or post-fracture, or there may be underlying malignancy, or sometimes you may find in the investigations provided in the questions some details about a likely malignancy like CT or ultrasound or even a CPC, which may show some lymphomas, for example. Also patients with pregnancy, so this is a hypercoagulable state, so acute dyspnea during pregnancy, you must always put in your differential diagnosis pulmonary embolism. Also, for a patient presenting with a DVT or unprovoked DVT or a DVT in the upper limbs, so also you must think in thrombophilias like protein C deficiency, protein S deficiency, factor V Leiden mutations, or antiphospholipid antibody syndromes. So these are the common scenarios which you will see in real life practice and also in the exam. So we start with some tips in utilizing diagnostic tests. You may be asked about a best initial investigation for a patient with clinical picture suggestive of a pulmonary embolism. So Ddimer may be provided in the question, so may be provided that's negative or positive, or you may be asked about the initial test and Ddimer is given at one of the choices. Ddimer usually is recommended if the patient with a low clinical probability. So for example, if a patient presenting with dyspnea, chest pain, and there is a likelihood for pulmonary embolism, however there is no risk factors at all, and there is no criteria suggestive of a pulmonary embolism. In this case, you may request a Ddimer. And if it's, as we know, Ddimer is a good negative test. So a good negative test and a low clinical probability usually excludes pulmonary embolism. And however, a positive test is a non-specific, as we know. So it's a good negative test. It has a good negative predictive value. It has a high sensitivity and low specificity. The other investigations is CT pulmonary angio. Almost CT pulmonary angio is your choice when the question asks about the definitive diagnostic test. So definitive diagnostic test in a patient with suspected pulmonary embolism is almost always CT pulmonary angiography, especially if the patient has a high or intermediate clinical probability. So if you have a patient with a high clinical probability, so with multiple risk factors for pulmonary embolism, and even if a Ddimer was negative, so you must go for a more definitive test like CT pulmonary angiography. Also ultrasound Doppler. If a pregnant lady with a clinical feature suggestive of pulmonary embolism and has clinical feature suggestive of a DVT, the best initial test for this case would be ultrasound Doppler. So you will not go for CT pulmonary angiography or VVQ scan. If ultrasound Doppler is positive, so that would be enough for diagnosis of pulmonary embolism. Usually echocardiography is the first initial investigation if a patient presented with shock and a picture suggestive of pulmonary embolism. And in this case, echocardiography is the best test to exclude and not to prove the diagnosis. So a negative echocardiography will exclude pulmonary embolism as the cause of shock. VQ scan also, this is an important test, and usually would be a good choice in scenarios during pregnancy. So if a patient has a high clinical probability and has some contraindication to CT pulmonary angiography, VQ scan would be the initial or the best investigation for the case. So if the patient has allergy to the contrast material, or if the patient has significant renal impairment, or there is a history of breast cancer, family history of a breast cancer, or there is recent angiography that was done before. So in this case, VQ scan would be the first and the most important test. This is especially important during pregnancy. Also, in the question, you may be provided with a chest X-ray result if a pregnant lady with suspected pulmonary embolism, and if the chest X-ray was normal, and you have been given the choices of a VQ scan, so VQ scan will be probably the best test in this case. Chest X-ray is also is an important test. So if you have a pregnant lady presenting with suspected pulmonary embolism, and you also asked about the best initial investigation, in this case, you have to start with a chest X-ray to exclude any other potential diagnosis before proceeding with other investigations. So again, the Ddimer will not be an option if the patient is pregnant, post-operative, post-traumatic, or the patient has a clinical feature and an evidence for DVT. So requesting a D-dimer in a patient with DVT also does not make any sense to confirm or to exclude a pulmonary embolism. And so usually, as we said, requesting a D-dimer is only requested for low clinical probability cases. However, a negative D-dimer in a high clinical probability, that means a patient with suggestive clinical feature, multiple risk factors, or a strong clinical feature of a DVT, will not exclude the diagnosis, and should not be requested by all means in a patient with confirmed DVT, because it will not add to the diagnosis. Also, it's a very important clinical practice when you are asked about the best initial action for a patient with clinical features suggestive of pulmonary embolism, and there is strong evidence that there is possibility of pulmonary embolism. It's a good practice to start with anticoagulant, so give heparin and proceed with your investigations. Regarding treatment, many treatment options are available for patients with pulmonary embolism. So if the question asks about the best initial treatment or the definitive treatment for the patient, you have to be aware about the question. So if a patient, for an example, if a patient with a pulmonary embolism during the pregnancy, and the question asks about the best treatment, of course it would be heparin, by low molecular weight heparin. So if the patient has a history or investigations that are suggestive of antiphospholipid antibody syndrome, so a patient with recurrent miscarriage, so the best treatment here for these cases would be low molecular weight heparin plus aspirin. Of course, warfarin will not be given during pregnancy. It's not preferred to give during a pregnancy. It's very important, that by default the treatment of pulmonary embolism is anticoagulation. So starting with heparin and doing some bridging with oral anticoagulants, and then continue with oral anticoagulants like warfarin. Regarding the novel oral anticoagulant, they must not be used in patients with suspected or confirmed antiphospholipid antibody syndrome, because there is risk of increased thrombotic events in these cases. So the treatment for these patients will be warfarin for life. During pregnancy will be low molecular weight heparin and aspirin. That's continued throughout pregnancy and for 1 to 6 weeks after delivery. Of course, you have to be aware if the patient developed heparin-induced thrombocytopenia or HET. So in these cases, you would avoid the use of heparin in these cases, and you are going to give alternatives like leprodine or herodin. The use of thrombolytics if the patient presented with hypotension or shock and a clinical feature of pulmonary embolism, the initial treatment and the best treatment would be thrombolysis. If there is absolute or relative contraindications to thrombolysis, you may go for thrombectomy, either surgical or percutaneous thrombectomy. IV fluids are very important, especially if the patient is shocked. So one of the initial steps is to start with IV fluids if the patient presented with shock. So even before starting thrombolysis. And inotropic support also is on during giving during the management of patients with shock. You would give fluids and inotropic support if the blood pressure does not improve, with fluids and thrombolysis only. Thrombolysis, of course, include streptokinase or maybe TBA. Either you may give streptokinase by the conventional dose or by the accelerated regimen. So don't forget, novel oral anticoagulants are not given in antiphospholipid antibody syndrome. Warfarin is not used and not preferred during pregnancy. Aspirin is added to heparin in patients with antiphospholipid antibody syndrome. Low molecular weight heparin is the treatment of choice in patients with malignancy. So if a patient with malignancy and the pulmonary DVT and the pulmonary embolism, the treatment is low molecular weight heparin and not to give warfarin at all in these cases. And finally, thank you.